Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
Good afternoon, everyone. It is an honor and a privilege today. As most of you all know, I have such a love for hospice. I started as a hospice nurse early in my career, and still my favorite patients to work with are hospice. But as a brand new hospice nurse, I worked at a company called Family Hospice. And the medical director there was a gentleman named Alexander Peralta. He is one of the most well-known hospice physicians in the United States and beyond. And I have the privilege of having him as a guest today. Dr. Peralta, thank you so much for being here.
Thank you very much, Joe. It's a real pleasure and honor to be here with you today.
You know what I loved about you as a brand new nurse, we learned about a paragraph about hospice in nursing school. And so everything I learned as a new nurse was really from you. And you taught just how to be at the bedside, how to show compassion, how to meet the clients and patients where they were, how to interact with family, how to address pain, how to understand the dying process. I could go on and on. So anyway, we're just going to talk about hospice today. We're going to talk about euthanasia, palliative sedation, hospice. And just so, Dr. Peralta, you can help the public understand the difference and what options there are. So we're going to talk about, I just want to talk about hospice. So talk to us about the history of hospice in the United States.
Very good. Thank you very much, Joe. Yes, in fact, I can speak to that because I actually worked with Josefina B. Magno, who started the hospice here in the United States. She was a Filipino physician whose husband had cancer, was seen at Memorial Sloan Kettering, and she made friends over there. And then as a medical director of, at that time, Family Hospice, I have my own company now, Palliative Medicine Consulting Services, and I'm a medical director for Nights of Comfort Hospice. But at that time, I heard Joe speak. And I said, we need to hire this person to help us work with a family hospice. And so eventually, after many discussions, she agreed to be part of our faculty. She lived in Southfield, Michigan, so she would come and do lectures. But to tell you a little bit about Jo and where her heart was, she was a cancer survivor. So she actually moved after her husband passed away to Washington, met a couple of friends there, and then all of a sudden she found herself at Georgetown University, and so she became one of the first fellows in medical oncology. She got breast cancer. And then sitting there with patients that were getting radiation therapy, she thought all of them were sad, all of them were discomfort, all of them had pain. And she had read, just like you, a paragraph about Dame Cicely Saunders doing hospice in the United Kingdom. And I just said to them just outside of London. And so she went. She went over there, spent her time, spent 6 months, learned from Dame Cicely Saunders, and came back. She came back to the president of Georgetown University and said, it is our obligation and our duty for us to start hospice here. Now, hospice had already kind of started at Yale University in Connecticut. They had the first hospice, and actually Dame Cicely Saunders and Sylvia Lack had come in and helped start that particular one hospice, all volunteers. And so Joe said, yes, hospice is a very important part of it. So we had, she arranged for the first meeting of all hospice professionals, and it was that time a National Hospice Organization back in 1978. And she said, we need to have some high-profile speakers. So she invited Joseph Califano. Probably a lot of people know who he was, but he was actually head of health education. And then she invited Ted Kennedy. And wow. So Ted Kennedy was the closing speaker to this symposium of 1,000 people. And that's how hospice got started in the United States. Wow. 1,000 people came to Washington to this 4-day seminar and learned about hospice. And so Joe, in a very compassionate and motherly way, sat next to Ted Kennedy, and he had a prepared speech by his staff. So, but after listening to Joe for about almost an hour and a half while dinner, and so the speaker spoke, he got up, he grabbed his speech and put it on the side. He said, "I was going to tell you about hospice care, but I don't know anything about it. Joe Magno has taught me about this. Let me tell you, my father, Joseph Kennedy, is dying, and he has all the help he needs because we're able to afford that. But people who are dying need someone to help them in this dying process. So we're going to work on a benefit that creates hospice care in the United States." In 1982, 1982, the law passed, Tax Equalization and Act, and that actually made it lawful, conditions of participation. And in 1983, it got funded. And so we were the first managed care program, the first per diem program in the United States, run by CMS. And so that gives you an idea of working with Joe Magno and the magnitude that she had in really helping us. And Joe's commitment was two things: teaching it very much as a holistic type of care, and to focus on four major domains. And most of this came from an article that came out by Eric Cassell back in 1982 in the New England Journal of Medicine. And he talked about suffering. And he said we needed to address the physical, the social, the psychological, and the spiritual aspects of care. And they're the major tenets of hospice now. Were then and still are now for hospice care. But Joe had a tremendous passion for doing this. And I'm putting together a book called Breakfast with Joe because she introduced me to all the people. And she never really, she worked with the local people, but she always went to the top. Ted Kennedy and other presidents as well, trying to get support for hospice care. And candidly, for me, hospice care is intensive human caring. It's a very unique way of providing care for people with an illness that has no hope for cure. And I think Joe taught us that. He says, if they have no hope for cure, what other options do they have? And so hospice was the answer of providing that. And now hospice is one of the very large part of CMS. There are thousands of hospices, for-profit and not-for-profit hospice in the United States, and all providing care. And I will not mince any words, but we're being challenged now from CMS because of cost, because of people not doing hospice correctly, and the care that they're providing. So it's a challenge right now to really do hospice care. But I know what it was when Joe practiced it, when I practiced, and still practicing. It is an opportunity really to help patients in a very, very difficult time in their life and provide comfort.
Yeah, very well said. So I know a lot of people say, "Oh, don't say the H word. We don't want to mention a hospice." So, a lot of people think hospice is giving up, and it's so far from that. So can we talk about that myth? Tell me how do you talk about hospice care as a positive service?
Well, first of all, I'm going to let you know that from a wonderful friend of mine, Maggie Callanan, who wrote the book Final Gifts, none of us make it out here alive, okay? There was a recent podcast, NPR News, about this wonderful professor that talked about, a person 116 years old, we're not going to make it. So all of us will need hospice care. We're all going to die. And so we're hoping for that unique opportunity. Unfortunately, the crux to the situation of hospice is what Joe said a long time ago to Joseph Califano when he asked, how long can a person be on hospice? And in 1983, she really didn't know. So she said, about 6 months. And that 6 months or less has been really a real challenge for both clinicians and families as to know at what point, or what I call a stoichiometric point, does a terminal disease become fatal. And so subsequently, that's a very hard decision. But now, in this day and age, you have options. And I think you mentioned that. People understand about palliative care, which is focused very much on the same tenets as hospice is concerned. But people are not dying on palliative care. There's the symptom management, it's a care, it's supportive care provided. And also the fact that after a certain period of time, people get discharged from hospice, and it really confuses the family. But you can, at that time, switch over to palliative care in the front end and the back end. And there's people who provide that care on a daily basis to provide that continuum of care, plus all the necessary medications and supplies that the patient needs because of their disease processes. So palliative care has come, and I had the privilege of starting the first 41 fellowships in palliative medicine in the United States back in 2005 with University of North Texas Health Science Center in Fort Worth. And it was a new subspecialty. And it's still now one of the strongest subspecialties because there's 10 boards that offer subspecialty in palliative medicine and hospice care. Because all of us will need at some point in time a way in which we can connect our patient with the type of services they need, especially those that are acutely ill and require ventilators and CPAPs and IV medications and all these things. We need to help them transition from the acute care setting to the home setting and make it as comfortable as we can.
You know, it's funny you mention about people coming off hospice. So a lot of people don't understand that. And my grandmother lived with us her last year of her life, and it was just an honor. But she was given 2 weeks to live. She was not taking her medicine correctly. If she was going on an outing, she wouldn't take her Lasix. You know, she had congestive heart failure and the fluid would build up, and then she'd get short of breath, and then she'd have to have oxygen, and she'd have to go to the ER. Anyway, so we got her meds. We got her stabilized with her meds, with her oxygen, had a nurse come out, weigh her, and she wound up living for 11 months. So we were told 2 weeks. But with hospice in place, we had several wonderful months with her. So, and I've seen so many patients that they're just not able to, I mean, even me, I don't have memory issues and I forget, have I taken my medicine this morning? So imagine somebody with some cognitive issues. So if you've got somebody overseeing their meds and maybe they do need a hospital bed at night so they can elevate their head. So many things that hospice and palliative think about really allows a better quality of life. So sometimes people will come on hospice and they go off hospice, and that's great. That's good. So let's talk now. I know Texas does not allow euthanasia. Mm-hmm. There's several states that do. Mm-hmm. So explain to us, what is the difference between euthanasia and palliative sedation?
Sure. Okay, I just want to make one point about hospice. Is that, and I think Joe mentioned it. It's a team approach. It's a holistic team approach. And so you have not only the physician, but also a social worker, a chaplain, home health aides, and people come into your home and really provide supportive care. And just to what you mentioned is maybe they're not taking their medications correctly. Maybe they're not being weighed. Maybe they can't afford to take all these medications. So finally, somebody with heart failure or pulmonary disease, all of their symptoms are being controlled. They're taking everything correctly, and they have this big turn of events in which the acute on chronic illness becomes prolonged, and then therefore, they say, well, it's been over a year that they've been on hospice, and unfortunately, we're obligated by the CMS to discharge them at that time once they stabilize. So I just wanted to make that point. Mm-hmm. Okay, so let's talk about palliative sedation. Before I start about the palliative sedation, first of all, it encompasses a broad range of activities aimed at taking care of patients with terminal illnesses. But palliative sedation is addressing refractory symptoms, okay? And that could be short of breath. It could be a bowel obstruction. It could be a seizure disorder. It could be a fact that they need a ventilator and need oxygen. But palliative sedation then, and I'll share a story with you because it had to do with my first patient. One of the first patients that I took care of early in my career was a young woman in her 40s who had breast cancer metastatic to the brain, the lung, the bone, the liver. And she had 3 young kids, and her husband was an attorney in Dallas. And so the medical oncologist asked me, he said, Dr. Peralta, she is on a CAD pump, which is an IV pump, and she's on 100 milligrams of morphine an hour, and I can't control her pain. Can you help me? And I said, sure. And I've had the privilege of working with people from throughout the United States on pain management, Memorial Sloan Kettering and MD Anderson. So I had knowledge in opiate therapy and pain management. So I got there, and I'll never forget this for as long as I live. So I got there, and I sat with her in the breakfast nook, and she has as kids were in school, she had a 5-year-old, a 6-year-old, and a 10-year-old. And she sat there, and I said, well, we've enrolled you in hospice, and we're going to try very hard to manage your pain. And she kind of grabbed me from the shoulder, stood me up, looked me straight in the eye, and said, trying is not good enough, Dr. Peralta.
Oh, wow.
My life depends on it. So I'm expecting you to more than just try. And I said, and after she cut me down to about 2 inches. So then I got back to my own height. And I said, we're going to do the best thing we can. So she was on 100 milligrams of morphine an hour. That's a lot of morphine. So we titrated her. We did what's called opiate rotation, which was switched her from morphine to hydromorphone, more concentrated, 5 times more potent than morphine. At that time, we were not using IV fentanyl, which I've used in pediatric patients in the past. So her final dose, the last 8 weeks of her life, was 125 milligrams of hydromorphone an hour.
That is
You
crazy.
multiply it times 24, and that's a lot of hydromorphone. But she was able to do some very important tasks. She did a video for her kids.
Oh.
She wrote letters. So when they graduated from high school and college and had their first child, she had that opportunity for 8 weeks to write her legacy. And that's what she meant when my life depended on that.
Absolutely.
So that was a form, because if somebody tells you, I have a patient on 125 milligrams of hydromorphone an hour, they say, well, you're trying to kill them. I said, no, that's palliative sedation. It's managing refractory symptoms. And you can look this up in the definitions on palliative sedation in patients with terminal illness from the National Library of Medicine. And there's a lot of controversy about that, because there's still a lot of people try to interpret what that is. But the reason you use palliative care, and I'm going to read you what it says here, is that it's to resolve and alleviate refractory symptoms at the end of life. The most common refractory symptoms in terminally ill patients are delirium, intractable pain, shortness of breath, and bowel obstruction. There is a well-established practice and relatively acceptance of the use of palliative sedation to relieve these symptoms, but you're addressing symptoms. And this actually was the original word of a group of people in Europe, Charters survey back in 1997. They wrote the first article on palliative sedation. But most of us have used, because there's another name for it. They call it terminal sedation. That's what we called it when I worked in acute care. And that we use sedation to withdraw and withhold life-sustaining types of therapy, like taking people off the ventilator or feeding tube and things of that sort. So that's what palliative sedation is. And so that's what it does. The intent is always to take care of refractory symptoms. Of course, sometimes when people finally get comfortable, they pass away, but that's the intent. With euthanasia, the intent is to cause death. And it's totally, totally different, okay? So the intent is to cause death. Now, in between, now we have middle ground. We have middle ground because there's 11 states that allow what's called physician aiding dying. Okay, and let's take a second. There's these states then have certain rules and regulations as to how that's done. And like palliative sedation, before I start that with any patients, in my experience, primarily in withdrawing ventilators on patients with ALS, is I have a talk with the family. I meet with the family, and I I tell them just exactly what we're going to do, and then we choose a time and a place to do it. I explain to them the medications that are going to be used, that are sedative, medications for pain, for comfort, or in case they have seizures. So we have all these medications available, and we can do this in the hospital, and we can do this at home, and do palliative sedation at home, and that's really very, very challenging. And you have this long discussion talking about ethical issues of, autonomy and beneficence and non-maleficence, and also what the family's wishes are if they have a living will. So you want to make sure that you've touched on all the ethical principles, that family understands what you're planning to do. And then I always give them the option. In the middle of it, you just change your mind, that's fine. You can do that. Patients need to know that they have control over that, and they can feel comfortable, because sometimes you'll have a relative in the middle of this palliative sedation process say, "No, stop it. We'll honor that. We'll back off. We're not here to really make people upset or have them create a sense that they didn't do something they should have done." So therefore, the principle of double effect is used in this process of palliative sedation and euthanasia. But the principle of double effect is, what is your intent? And your intent is to address refractory symptoms. Euthanasia then has to do with actually giving the medication. Now, I will let you know that this is not anything new. If you know Greek mythology and Greek history, you know about Socrates, and you know that in the forum, they decided that he was influencing young people. And so they said that they were going to actually execute him. So what he used was a certain plant, and that plant has hemlock.
Wow.
And he actually committed suicide by taking this particular hemlock potion. It's an alkaloid, okay? And so it's not something that's new to us, because that was back in 399 BC, okay? Mm-hmm. So it was a long time ago. But it's still a conundrum for a lot of families. It's a very difficult decision. And so now people, and this all really started back in 1996 with the state of Oregon, with the Death with Dignity Act. And what's very interesting about the statistics of the first 10 years of the Death with Dignity Act in Oregon was the fact that the majority of the people, more than anything else, it was not the pain or the shortness of breath or the disease. It was candidly the loneliness of the disease. Mm-hmm. The loneliness. And only that patient knows the loneliness of the disease. You see it in patients with cancer, with end-stage pulmonary disease, end-stage heart disease, but you also see it in patients with Alzheimer's disease. The loneliness of losing their cognition, of not being able to do the things they were able to do in the past. The loneliness of the disease, more or less, is what was the main reason that they wanted to commit euthanasia. Or now, it's actually, you're not allowed to do euthanasia like Dr. Kevorkian did. We drove around people and gave them carbon monoxide in the back of his truck and then rolled them over in one of the hospitals in Detroit. It's actually physician aiding dying. And it's a very elegant and a very respectful way of honoring patients' wishes, and making sure that we respect the autonomy of the patient, but we are ethically and within an ethical structure that we're not breaking any laws. So, Texas does not have is not one of the states that actually provides euthanasia. And
these states, the 11 states, so are people allowed to come from other states?
Yes. And I think the first state besides Oregon was Vermont and Maine and New Mexico now, and several. There's a total of 11 states that allow it. You have to create residency in that state. Some states require 6 months, some states require 1 year. But then you have to go through a certain protocol in which you actually are examined by a physician. You determine that you have a terminal illness, and that also the fact that you have also a psychiatric evaluation, that you make sure it's not depression that's driving your wanting to get euthanized. And also it brings the family to its consensus that everyone in the family agrees that this particular process of physician aid in dying can be taken to fruition, and so that the patient achieves the goal that they wanted to.
So question. So somebody, let's say somebody who resides in Vermont gets a diagnosis of dementia, and they do not want to be a burden to their family. They know that they're not remembering words or whatever. How early can somebody be euthanized?
Well, and that's a very good question, and there's really no straight answer to that. They have to be evaluated appropriately by the medical personnel. And usually then would be along with a psychiatrist. One thing that's very important in all of this is that the person must have decisional capacity. Okay? And decisional capacity looks at ethical construct and 4 core abilities that the patient must have. I do this often for some families, to making sure that the person has decisional capacity. And it has to do with medical power of attorney and things of that sort. But the patient must have decisional capacity. If not, then they have a surrogate. And then, of course, here in the state of Texas, with the Advanced Directive Act, which is actually called another name as well, you're allowed to have a surrogate that makes decisions for you when you can no longer make decisions, okay? And you give that person that ability to make that decision for you.
Wow.
Okay.
Yeah.
And so, yes, and it becomes a medical legal situation at times, because it could be a person that says, well, I want everything done. But then after evaluation, the person really has no hope for cure. They have a terminal cancer or terminal illness, and they have no hope for cure, and they can't make decisions anymore. Then the surrogate can step in and ask for hospice, palliative care, or if they live in the state, can ask actually for physician aid in dying.
Wow, that's very interesting. So what are the laws? I know Texas does not allow euthanasia, but it does allow palliative sedation.
Correct.
And so just, touch on this. I know you gave the example of the young woman with breast cancer. What is your typical palliative sedation patient look like?
Well, and the first palliative sedation patient that I did, besides the first one I talked about, which I really didn't know it was palliative sedation at the time, back in the early 90s, was a gentleman with ALS. And so he lived outside of the Fort Worth area. And so we have a protocol. We say we need to visit with the family. So at that time, our hospice then visited with the family, the father and mother, and his children and his wife, and visited him, told him. And he said, no, I'm ready to withdraw life support. I'm ready to stop the ventilator. And so then we that's our protocol. And we give them 10 days to kind of think about it. Then we go back and we have another visit, making sure that that's what they want to do. And then we go ahead and start the process. And for this particular patient, when we arrived at his home, there was 50 people there at the home.
Wow.
And so he had already decided. And I think one of the things that really kind of helped me make that decision to help was that his son asked me if I would help his dad have a peaceful, comfortable, pain-free death in the setting of his choice. And I looked at him and he said, you know why, doctor, I'm asking you this? Because I have ALS too.
Oh, wow.
And I said, and I want my dad to die comfortably. So at the bedside with his wife and his family, all there, we got him very comfortable to the point where we could withdraw life support, which is actually turn off the ventilator. And this is a difficult thing for families. I've done this many times with families withdrawing life support, both in the hospital, which is really nobody thinks about it, but we've been doing it in the hospital for a long time, withdrawing life support. But at home, it's kind of like a different thing altogether. And I always give an option for the wife or a family member to say, do you want to turn the ventilator off, or do you want me to turn the ventilator off? And 100% of the time, well, at least 50 patients that I've taken care of, have done pelvic sedation more than 50 times, but the 50 patients that have withdrawn life support from, the family wants to do it.
Yeah. Well, they've got to accept
the final action.
It's closure.
Correct. It's a very important closure. And it's the most difficult thing we do in our lives.
Yeah.
It is. It's a real challenge.
Yeah, saying goodbye. That's just so hard. And I just think about that dementia diagnosis. Ronald Reagan lived how long? 14 years with dementia. I mean, and my mother had dementia. She had it for 9 years. And so I know what a burden that is. And I'm not saying I agree or disagree. I just, I know I don't want to be that kind of a burden on my family.
Sure.
So what are you, Dr. Peralta, what are your thoughts on euthanasia? Would you like to see that allowed in the state of Texas? Tell me your thoughts.
Well, I think that there's a lot of other modalities before we come to that particular area. And I'm speaking for my Christian background, although, there is a very well delineated, the archdiocese in Dallas and in Texas and the United States, a very delineated end-of-life pamphlets and information actually for that talk about that. But that's a very difficult thing because, I also took care of my mom with dementia. And so that was a very difficult thing for me to see that wonderful woman from San Antonio that took care of us, that worked so hard, that really pushed us to get an education for my family and my brother and I and my daughter, my sisters, so that here she's confused and disoriented. And then while in my home, she stopped eating. Okay. And what a conundrum when the rest of the family says, what are you doing to mom? You're trying to poison her? You're trying to starve her? And so, and it's very difficult.
It's hard.
It's a real challenge. And that is the biggest challenge for hospice right now because of the longitudinal trajectory of Alzheimer's disease for patients. Sean Morrison, a brilliant writer with Mount Sinai, has really touched this topic because it's difficult. The family needs help. The family needs supportive care. I've spent the last kind of 24 years since my mom passed away in 2000, April of 2000, studying Alzheimer's disease. And one of the things two things that I want to share with you toward the end is the first thing is that there is the neuroscience of Alzheimer's disease, but there's also the mind. And so the mind then causes a lot of the behavioral and psychological symptoms of dementia: confusion, disorientation, aggressive behavior, hallucinations, a disease process, especially patients with Parkinson's disease. But the last thing I want to say is a person's oneness of who they are. The oneness of who we are is very, very important. That's who we really are. And we make that decision as to who we really are. And when you're making decisions for your loved ones, that's what you need to really go back to who you are, the oneness. Then that word comes from a wonderful book written by Stephen Levine, Beyond Death and Dying. And so it talks about first knowing who you are and feeling comfortable with that, and then moving on to helping other people with that particular notion of trying to provide care. With Alzheimer's disease, you can have a variety of different Alzheimer's disease. We all know about this. Really, these beta amyloid plaques and tangles will continue. The only difference between Joe and I is that Joe clears it probably because she's younger at 70%, and I clear it at something like 20 or 30%. So I accumulate all of these amyloid plaques and tau tangles in my brain. And so subsequently, that causes the progressive neuronal loss, which we have, and also the synaptic failure, connection between neurons. That could be another talk. But anyway, the Alzheimer's is a very challenging disease, and to make decisions, okay? Now, I will tell you that there is a major topic called VSED, voluntary stopping of eating and drinking. It's a lot of discussion about that. But candidly, that could be an exit strategy. Because if you stop eating, now I weigh 190 pounds, so if I stop eating, I'm going to last several months. However, if I stop drinking, I would only last 5 to 7 days. So that's also an option for that person once they know and they feel comfortable with what's happening to them. Okay. Don't suggest that to do that to your family members, but to make sure that everyone, and you're seeking good counsel from your physician, from your specialist, from your palliative care physician, and from your hospice physician, so they can direct you to provide that care.
Well, and my last question for you, and I know you know this, as a medical director of a wonderful hospice, Nights of Comfort, but so many doctors now, and I hear from hospices that the doctors wait too long to refer to hospice. And why do you think that is? As a doctor, why do you think they wait?
Well, I think, it has to do with Hippocrates and the oath that we took and trying to help patients and all the things. I would, honestly, for me, is I had the notion when I finished my residency training at UT Southwestern and Methodist Hospital, I thought I could cure everybody. And then I learned about hospice a couple of years later, and I said, you're not keeping everybody alive. You can't do that in a ventilator and things of that sort. So it came with peace within myself to know that. I think physicians have a tendency to want to do as much as they can, but I think that they also need to realize that they need to bring the family. And the family, if the physician says, no, I don't think you're ready for hospice, the family has a right and the responsibility to say, okay, I'm going to contact hospice directly, and I want a hospice consult.
Just an evaluation.
Evaluation of that palliative care evaluation or a hospice evaluation to see if I really qualify for hospice. Okay? Because many doctors don't really understand how hospice works, how it's reimbursed, what the local coverage determinant is. They don't know about what's the new word in hospice. It's called the ICF, the International Classification of Function and Disability. But basically what you're looking at is terminal disability. So there's a lot of kind of medical legal language, as well as there's a lot of information as to how we handle patients at the end of life. And when is the right timing for that?
Mm-hmm. Thank you so much. Dr. Peralta, your information has been so wonderful. If somebody wants to reach out to you, and people listening, I so admire the work you do. And if somebody would like an evaluation, and I know you're the medical director with Nights of Comfort, and I've had patients that I've been working with as a nurse navigator, and I can say they do a great job. They're wonderful. The whole team, social worker, chaplain, visiting nurse, nurses' aides. I've just been so impressed. But how can somebody reach out if they want to be evaluated by a hospice team and the doctor says, you're not ready for hospice? How would they reach out to you guys?
I have two ways I think that they probably do it. One is asking the physician if they have a palliative care team in their hospital, and could they be evaluated by the palliative care team. And then you can actually reach out. Bob Fine, who's been a mentor and an excellent physician, has led palliative care, and Mark Casanova have been excellent. So, and they have their own palliative care program, and they have an outpatient clinic, okay, that people can actually access. And I want to be evaluated. I want kind of like a second opinion or a third opinion.
Absolutely.
So that you can get an idea as to whether hospice or palliative care is appropriate for you.
That's great.
Okay.
And you encourage a second opinion.
Absolutely.
Yeah.
Absolutely. There's nothing wrong with that. I mean, and I take care of a lot of friends of mine and patients with cancer, and they say, well, I went to this oncologist or that oncologist, and going like, you have choices. Okay, you can get evaluated at Memorial Sloan Kettering. You can get evaluated at Mayo Clinic. You can get evaluated at MD Anderson. So but people have to know that they did everything they possibly could, because at the end of the day, they have to sleep comfortably and know that everything they could have done for their loved one has been done. Mm-hmm. And you can have a nice, restful sleep.
I know.
Yes.
I agree. Dr. Peralta, thank you so much. And a phone number at your office that somebody could call. Is there a number or an email? How do we get in touch with you?
They can reach me at 469-955-8191. And then if you want to look at the website for Nights of Comfort, you have the website there. Okay.
Great. Thank you so much. It's just been an honor. Thank you. Have a great day. And I know people will reach out to you, and I highly recommend reaching out. So thank you so much. Y'all have a blessed day.
Thank you. The same to you. Bye-bye.